Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Lessons from Lockdown, Viral Hepatitis Testing and Treatment in the COVID-19 Era. I'm delighted to introduce our expert faculty today, both of whom have too many professional appointments to list, so I'll abbreviate. I'll start with Dr. Nancy Reau. She's Professor of Medicine and Chief, Section of Hepatology at the Rush University Medical Center in Chicago, Illinois. I'm also pleased to welcome Dr. Jordan Feld. He's Professor of Medicine at the University of Toronto and Hepatologist at the Toronto Centre for Liver Disease, both in Toronto, Canada. To link to the full program online, including a complete list of our faculty's affiliations, please visit the show notes for this episode. So let's get started and hear what Drs. Reau and Feld have to say about lessons learned in the management of viral hepatitis during the COVID-19 pandemic.
Hello, I'm Nancy Reau from Rush University Medical Center, and I want to welcome everyone to Lessons from Lockdown. I'm joined by my colleague, Jordan Feld from University of Toronto. Jordan, I'm going to let you introduce yourself.
Thanks, Nancy. Great to be here. I'm Jordan Feld, a hepatologist at the Toronto Centre for Liver Disease at the University of Toronto in Canada. Looking forward to this discussion.
So we all know how impactful COVID-19 has been, and our goal for this program is to talk about how COVID-19 has disrupted the elimination efforts for hepatitis C and hepatitis B, and also to maybe talk about some techniques and strategies to overcome this, as it appears that COVID is going to be with us for a bit of time. So we're going to start by looking at some of the AASLD data, if that's all right.
So when we look at the impact that we've seen of the pandemic, we've really seen it across the board on elimination. And this study there was a really nice study done by Maria Butti and colleagues from Europe looking at how the pandemic has impacted testing. And they looked at both testing for hepatitis B and testing for hepatitis C. And what they found was that there was a significant drop initially in hepatitis B testing. So they compared to pre-COVID era. So actually a drop in surface antigen testing dropped by a remarkable 39% from pre-COVID times to during the pandemic. And then when they followed that up and looked at HBV DNA testing, that dropped by a slightly less margin, but still quite significant, a 24% reduction. And this was across 34 different centers around Europe. And when they looked in a similar number of 31 centers and looked at HCV RNA testing, they saw a lower drop in terms of the absolute drop. So it was only 4% reduction, but this was still a highly significant reduction. And what we know is that testing drops, and the consequence of testing drops is that really leads to the more concerning feature, which is it leads to a drop in treatment. So what they saw, in addition to the reduction in testing, is that led to a significant drop in the linkage to care. So looking again at a similar between 30 and 40 centers around Europe, that they saw that with these reductions in testing, that for both hepatitis B and even more strikingly for hepatitis C, the rate of this testing going on to a consultation dropped dramatically. So for hepatitis B, they saw that there was a 30% reduction in outpatient consultations and almost a 40% reduction in new referrals. And for hepatitis C, that was even more striking, with a 45% reduction in outpatient consultations and just under a 50% reduction in new referrals. So what we see is that this screening really cascades down the cascade of care, leading to a profound drop in the linkage to care. And then what we've seen elsewhere is that really translates to reduced treatment starts. And that's, at the end of the day, really putting a wrench in our efforts for elimination.
Yeah, so I think that we've always struggled, even pre-COVID, with the care cascade, knowing that screening rates were, even if substandard, are still much, much higher than linkage and initiation of treatment. And so I think that to put that into context, that drop off is pretty remarkable. Now, did you see the same thing in Canada? I know that's a European study.
So yes, we also looked at hepatitis B and C testing in our province of Ontario in Canada, and we used public health laboratory data to get a sense of the whole regional changes. And we looked at what happened during the different waves in the first 3 waves of COVID, and compared them to pre-COVID times. And we looked at this in different populations and in different settings and different types of testing. And what we found was very similar to what was seen in Europe, that we saw this big drop off in both hepatitis B and hepatitis C testing. The biggest drop off was in the first wave, but what I think was concerning to us is, even though we did see some rebound, is that rebound never got us back to pre-COVID levels. And the other thing I think that was concerning was that we saw that the drop off was greatest in the types of testing that would lead to treatment. So we saw that HCV antibody testing dropped off less than HCV RNA testing as a percentage. So you really need the RNA, of course, to get people started on treatment. So I think what we are concerned about, and I think what you saw in the US, and I'll let you speak to that in a moment, is that there was really this ripple effect of, you see this drop in testing, but the real problem is that that's actually leading to an even greater drop off in treatment, which ultimately is really limiting our progress towards elimination.
Yeah, so we saw something very similar. And so we did a mathematic model with Natasha Martin, looking at treatment through 2 large databases. So looking at both hepatitis C antibodies or screening metrics, and then the engagement in hepatitis C therapy. And like you said, there was a very significant drop off in screening. And in the US, we're lucky to frequently have antibody that reflexes to PCR. So we can't use that PCR to really look at that second step as well as if you had to use that as a measure of linkage, because this is often an autopilot, which is a good thing. So please continue to reflex. But even though the screenings rebounded, the initiation of hepatitis C starting treatment, which is kind of measured by showing that RNA becomes negative, it never rebounded. In our own experience, we looked at screening in our primary care clinics, our specialty clinics, and then the emergency room. And we found that screening in the ER really never stopped. It was kind of like an autopilot program. It didn't really matter if you had COVID or if you didn't have COVID. These things were so intrinsic now into how the ER worked, because we've had that program for so long, that they continue to screen for hepatitis C. But obviously, when you're trying to link things to care, COVID was strongly impactful, either in patients' nervousness, physician availability. A lot of our primary care providers were pulled into COVID settings, or even like the pharmacy concentrating on getting hepatitis C treatment over things like remdesivir. I mean, every aspect of treatment and linkage remains very challenging, even though our screening rates have improved a little bit.
Yeah, and I think that the treatment rates dropping off, I mean, I think sometimes people think, well, this isn't such a big deal. I mean, this is hepatitis C. If someone's treatment is delayed by a few months so they don't get linked to care immediately, that's not such a big problem. But I think one of the things we really have learned over the last few years is that when you have delays in this, many people, especially for hepatitis C care, are at a point in time where they're either ready or not ready for treatment. And if you miss that window, you may never get them back. So even though, there's no great harm if someone's Hep C treatment is delayed by a few months until things recover, but what we found, and I think this has been seen really around the world, is that when you have that interruption, that delay of 3 months turns into the person never showing up and really getting lost to care entirely, which is obviously what we're trying to avoid, but I think has been a real consequence of this pandemic.
Absolutely. We learned that the hard way when we had older therapies. When you told someone that they didn't need treatment because interferon was so toxic, they heard, I never need treatment. And I have patients that come in now with cirrhosis or liver cancer, and they're like, well, I don't know. I was told this was mild. I didn't have to worry about it. I'm like, yes, that was 20 years ago. A lot happens over 20 years. And so, I think that it's selective memory from a patient perspective. They may not have been told that they never had to worry about this. But I think when we give them that message that COVID has disrupted linkage, don't worry about this until the pandemic is over, that this pandemic is not necessarily going to be over anytime soon. And we should be doing whatever we can to, get effective treatment. It's also very important to remind listeners that a lot of our substance abuse treatment programs have been disrupted by COVID. And because of the psychosocial stressors of the pandemic, there are individuals who didn't struggle or had very well controlled alcohol use disorder or, injection drug use that now are using again, just simply because this has been such a challenging time mentally.
Yeah, and we've seen, interruption in harm reduction programs, and as a consequence, we've seen, I think, clearly documented in the US, increasing rates of new hepatitis C infections. And we've also seen, linked to the opioid epidemic, with really an increase in overdoses. So this has sort of really stressed the whole cascade, where you're actually seeing new infections with a reduction in prevention efforts. And then we've shown that you can still do testing, even if it doesn't drop off as much as it might have. That really translates to a real drop off in treatment starts. And then one of the other consequences we've seen is really down at the end of the cascade, where people with advanced liver disease, even those that are cured, are often saying, well, you know what, I don't want to come into the hospital and get COVID. I'll skip my ultrasound this time and not get my HCC surveillance. And I think some of the most devastating cases that have really you can't get those out of your mind is when the person who had missed 2 ultrasound tests for post SVR HCC surveillance, and then comes back with either a tiny nodule that's now an untreatable HCC, or really even had nothing, and then coming in with a large cancer that is sometimes not treatable. And those are obviously the real devastating ones, and those are the ones we're seeing. I can only imagine all the people that are not even in care at all, and that's even been worsened by the pandemic. And I suspect as we start to look at it, we'll see that there's actually been increasing mortality related to HCC overall, as another consequence of this devastating pandemic.
Absolutely. We unfortunately have the same thing, that it's long been established that when you present with symptomatic liver cancer, that the treatment options are quite limited, better than they had been historically, but still quite limited. And our screening programs really do work. So that you talked a little bit about hepatitis B. And when we are thinking about C, the care cascade is in theory a lot easier because it's a finite treatment, and we talk about curative therapy. For hepatitis B, it's much more challenging because the guidelines, although do exist, the rules to engage a person in treatment are a little bit gray at certain places. There are clearly patients that meet every indication for treatment, but the majority of our patients may not actually meet those black and white metrics. And so there was a very interesting and provocative study looking at cost effectiveness for engaging individuals who are immune tolerant. So this is a group of people who have very normal liver enzymes, very high viral loads, and by traditional guidelines and current guidelines were recommended to not begin treatment because the risk benefit for a lifelong course of therapy starting at this time point wasn't felt to be there. But this recently published study looked at cancer prevention and different rates of potential cancer, acquisition of cancer. Jordan and I just explained, liver cancer is a devastating complication of end-stage liver disease. And with hepatitis B, you don't have to have end-stage liver disease. This is a time when even mild liver disease has a liver cancer risk. And the study showed that using a very simplistic rule, I have replicating virus, led to engagement of treatment. They felt that this was a potential cost-effective way of preventing liver cancer down the road. Now, I'm going to open this to Jordan in a second, but I want every listener to understand that this is not recommended by guidelines. Currently, we do not treat our immune tolerant population, with a few exceptions. And so the message is not that this is shifting right now treatment initiation, but it is a much easier way of determining a patient appropriate for therapy. So Jordan, what do you think?
Yeah, I think this was a really interesting study. I mean, I think there's a clear need for simplification of the hepatitis B treatment rules. In high income countries, we know that we lose people because they are told a few times, oh, you don't need treatment, you don't need treatment. And just like you talked about with hepatitis C in the old days, after you're following someone for a little while, they say, I'm going to stop going back to see that liver doctor who never does anything for me. And they fall out of care. I think that if you go into low and middle income countries, it's even worse, where often these tests that we use for complicated guidelines, HBV DNA and other testing, is maybe not even available. So whether or not someone qualifies for the AASLD or EASL guidelines to initiate treatment is unknown. So people really don't get care. And now, especially when we start thinking about the fact that we have generic, very effective nucleoside analog and nucleoside analog therapy, you could think about a simpler paradigm of saying we should just treat everyone who's surface antigen positive, and there's more interest in that. Now, of course, the challenge with that, and this might be a little bit of getting the cart before the horse here with this cost effectiveness study, is it's nice to show it's cost effective, but first you really need to show that it's effective. So we really need large studies to actually show that treating people early in the IT phase, they've got high viral replication, would that actually translate to benefits in terms of reducing the risk of cancer down the road? I don't think we have firm data there. It's certainly interesting, and there's, I think, more and more interest in treating this patient population, particularly IT patients that are a bit older, that get above age 30 and certainly above age 40. But even for younger IT patients, I think there's an interest in saying maybe we should just simplify this, move it to sort of like what we're doing with Hep C, where we just treat everybody. And I think hopefully those data will emerge. And this is, I think, a provocative study because it shows us with a number of different scenarios of what the cancer rates might or might not be, that even in many scenarios with pretty low cancer rates, this is still pretty cost effective and might push us to try to be thinking about doing the studies to maybe lead to revisions in the guidelines.
Now, Hep B is going to become more complicated because the diagnostics and the therapeutics are changing. And we're going to talk a little bit, I think, about diagnostics, but one of the most challenging things is that you would love to see hepatitis B have a functional or sterilizing cure, so a finite treatment similar to hepatitis C. And I think that we're going to get there. Jordan, I hope that you have the same enthusiasm.
I hope so. I definitely hope so. And I hope, and I think we have to be a little patient. It's going to be probably some bumps in the road, won't be quite as smooth as getting to 3 months of a pill a day for SVR for HCV. But I think we will be getting to much more effective therapy in the near, say, short to medium term, and hopefully that will lead to allowance of us to treat more people and simplify treatment and really make it easier than it is today.
Excellent. Well, I think that we can kind of segue now a little bit into some of the different strategies on where and how to treat. So, Jordan, I think there was some interesting ER based testing. I know that we have a very robust program, although, as I already admitted, the linkage care, and which leads to actual treatment, is a little substandard. But I think that AASLD, there was some data there.
Yeah, I think I was actually impressed to hear that the ER screening in your institution and in some other places continued throughout the pandemic, because I can tell you that our ER docs really just said, you know what, this isn't the time for Hep C or Hep B screening, and really dialed back this. But it was nice to see this was a study out of Europe, which showed again that they had antibody testing with reflex HCV RNA testing or surface antigen testing, importantly with reflex testing for Delta, so anti-HDV in those people who tested surface antigen positive, in just a little over 13,000 people, and they looked at what happened to them. And they found that they identified about 100 people with hepatitis C and 87 people with hepatitis B. Importantly, about a third in both groups were unaware of their infection. So this screening through the emergency room was really identifying new infections, which was critical. And then I think they did a pretty good job of linking people. So about 2/3 of those people who were unaware of their infection were linked to treatment to a specialist. And I think that's pretty good. We've certainly seen that linkage downstream is challenging. We took a little bit of a different take on this and kind of turned it around and said, well, if we're not getting testing people in the ER, maybe we can take advantage of something that's happening with COVID and try to get people tested that way. So we looked at testing people in the context of COVID vaccination. So people coming into one of the bigger psychiatric hospitals in the city where we know there's a high prevalence of hepatitis C, and that's where people were coming to get their COVID vaccination. We offered them point of care hepatitis C testing while they were waiting in the post-vaccination period during that observation. And we got very good uptake and found not surprisingly, pretty high prevalence of hepatitis C within the population. And linkage to care was challenging, but fortunately, we were able to do HCV RNA testing right at the time. So in addition, after they had a point of care antibody test for those people that tested positive, we took another sample with a finger prick dried blood spot test to do HCV RNA testing and really made sure we had good contact information. And because this was a psychiatric population, many people had case managers and other things to help with linkage to care. And we were able to follow most of these people up and get them treated. And we're continuing to do this as boosters and other vaccine strategies roll out to reach populations, which there's a lot of efforts in COVID to try to reach some of the more marginalized populations. And we know there's big overlap with hepatitis B and C. And if we can try to leverage that and take advantage of it, I think there are opportunities to actually improve our testing and linkage through COVID-19 public health efforts.
I think that's an amazing endeavor. We talked about it because our institution is a very heavy institution for COVID, admissions and screening, but we're never able to figure out how to do that screening and and point of care test. And so, that's a huge amount of work, but obviously very successful in that this high-risk population did have a fair prevalence of viral hepatitis.
We've actually seen it just as a side point, it is with hepatitis B and people getting dexamethasone they're getting screened for hepatitis B because they're getting high-dose dexamethasone when they come in with COVID. And we've identified quite a number of unrecognized hepatitis B surface antigen positive individuals and fortunately been able to link them to care at the time of hospitalization. So another sort of small opportunity that comes out of generally this devastating pandemic.
Right. No, but that's a really important point for clinicians. We recognize that hepatitis B reactivation in people who have core antibody can occur with things like tocilizumab, high-dose dexamethasone. And so just like our oncology, dermatology, rheumatology colleagues that are now pretty good at screening for viral hepatitis before initiating these biologics, the COVID is no different. So the last thing you need is reactivated hepatitis B on top of your COVID infection. So I'm going to turn to a different forum. So one of the things we definitely recognize is where you are screened impacts linkage. So the emergency room has always been a very challenging place to link care to. But if you're screened in a primary care clinic, in theory, your ability to get linked is often much better. Now, not pertinent to this program per se, because it's not COVID specific, but co-localized care. So if you get screened, linked, and treated all in the same place, those are always the most successful. But when we're looking at more marginalized populations, even being screened as an outpatient doesn't always lead to successful therapy. So another presentation that was given at ASLD looked at a very rapid turnaround between recognizing that you had hepatitis C and when you started to engage in therapy, so that they screened individuals and immediately, as we've outlined a number of times, I went to a hepatitis C PCR so that you have that confirmation test that's done kind of as a reflex, so that if the antibody is positive, the PCR is automatically done. And if that is positive, these individuals came back very rapidly so that they could engage in treatment in a very short period. This study is also really important in that it also looked at patient navigation for insurance, so that we know that in the United States, at least, and likely in Canada, that if you're underinsured, there are still lots of strategies to be able to get access to treatment. And so that they address that at that screening visit, so that it also cut down that delay in when a person could initiate treatment. And so this program was very successful. You can see that many individuals that initiated therapy did complete therapy, despite the fact that there was a fair number of unstable housing and injection drug use. This was a very challenging population, not the same as screening a very healthy primary care clinic and engaging them in care. And yet they still showed that they could initiate treatment that led to cure in a sizable portion of the individuals. Even those that may have not returned to follow-up, they're counted as failures, but we know that with a curative therapy that comes in around 99%, that if they did take their medicine but didn't return for their lab value, they still may have been cured.
And I think that was a nice example. And there were other studies of showing that really the care navigation, so getting people the help they need to either get their insurance taken care of, to get them to appointments, to get them through their treatment. And as you say, even for those people who don't do the SVR confirmation, we know that most of those people are actually cured. And so, I think one of the things that's interesting is we've talked a little bit about how you do screening in different settings and so I think you've made the really important point that reflex RNA testing for hepatitis C is critical. The standard paradigm of doing a hep C antibody and then making people come back to do a confirmatory test really leads to a significant drop off. And in the US, fortunately, most of the commercial labs have adopted reflex testing, which has really enabled at least elimination of one drop off in the cascade. I'll be honest, we've struggled with that in Ontario, and that's a challenge. We're trying to move to reflex testing, but I think that's critical. And then one of the important points I think you made is really about getting people the testing and linkage almost immediately. So if you can co-localize care, so in a setting where people are coming back to get opiate agonist therapy or something else, so that you can do their test and then right away get them linked to treatment is really critical, because we sort of know that those two big drop-offs are first getting the RNA, second getting linkage to care, and we can get rid of the first one with reflex testing. We need to get rid of the second one by really co-localizing care. And so I think one of the things is about thinking about how we use these tests very strategically. And there's been a bit of a drive to try to use point of care antibody testing. We're still lacking really good true point of care HCV RNA testing, which is, I think, still a challenge for us. The fact that even if you get a point of care antibody test, you've still got to go on and get an RNA test done through the lab, which takes some amount of time to come back. And I think we're hopeful that the Cepheid platform, as one and others that are in development, will get approved. It is already approved in Europe and will get approved in North America and allow us to have the ability to actually do HCV RNA testing right after an antibody test and allow someone to get started on treatment right away, and try to put those nice model studies that you, as you so nicely spoke about, and put them actually into practice where we have really good engagement with point of care HCV RNA testing. And one of the things that's striking to me is how quickly some of the tests were developed, good diagnostics were developed for COVID. And if we could try to leverage that knowledge and some of the technology and some of the push to actually get it done, I think we could probably get ourselves in a position where we might have point of care or rapid core antigen testing for hepatitis C, which is similar to HCV RNA, or even better, actually, HCV RNA testing. And if we could get the cost down and the speed up, we might be in a scenario where we could just actually get rid of hep C antibody testing altogether and really just try to identify people who actually have the infection so that we can engage them in care.
Yeah, and I think that the therapeutics for hepatitis C lead very nicely to this. So sometimes you really need characteristics about the disease, and we do not want to underemphasize them. You need to still stage a patient. So, we want to cure a patient, no matter, regardless of the degree of fibrosis, or, the cure leads to decreased risk of decompensation, liver cancer rates. But, you don't want to miss a person who has cirrhosis. When you consider, however, that our direct-acting antivirals are pan-genotypic, so that you do not need to fit the therapy to the patient per se, these very simplistic models of a core antigen that shows replication that can lead immediately to initiation of treatment is going to be revolutionary. We just need to make sure that the insurers or the payers or the system supports that. In the US, we still require genotyping for the vast majority of our patients, even though it doesn't impact our treatment management. So you just have to stop these silly rules.
Yeah, and I think some of it is trying to be, thoughtful and smart about where we use these, in quotes, more expensive technologies. So the current model of doing an antibody and then an HCV RNA, whether it's reflex or not, works very well in a stable outpatient setting, or maybe actually even in an opiate agonist therapy clinic where someone's coming back repeatedly. You've got reliable follow-up. But if you're in a setting where you don't have good follow-up, like the emergency room, like in a prison, like in a screening drive, then you really want to make sure that's where the point of care test is really important. Because if you tell someone, I'm going to do a test and come back in a couple of weeks for your result, you're never going to see them again. So you want to have the point of care antibody, and that's where the point of care RNA as a follow-up or core antigen would be extremely helpful. And then I think you might even think about certain scenarios where you've got a very high prevalence population. For example, we've done some studies in supervised injection sites in Canada, similarly in active populations of people who are injecting drugs, or prisons. The prevalence may be high enough that you could actually, it would be cost effective to go straight to a point of care HCV RNA or core antigen test and skip antibody testing altogether. But I think we have to be careful about this and make sure we don't say everyone needs point of care RNA, because that's probably not cost effective. Use it where it's helpful. Don't use it where we don't need it, so that we can make the system work. And then another strategy I like is using dry blood spot testing. I mentioned it in our COVID vaccination strategy, but it also works very well in rural or remote settings, or even in the emergency room, where we've had our emergent docs say, you know what, I don't want to counsel someone on Hep C. It's fine for you to do a point of care antibody test, but can you take the HCV RNA on a dry blood spot and get back to them with follow-up, rather than me spending time counseling them about their Hep C when they've come in with a broken ankle. And I think that's important when you work out the system issues, and so really sort of matching the test to the setting and the population makes sense, and we can leverage that well to really enhance the cascade.
Absolutely. I think that these algorithms sound a little more complicated, but ultimately are very simplistic. So a lot of words for something that would actually make everything a lot easier.
So, and then I think the other side, we've of course talked about hepatitis C and all the simplistic diagnostics. I think with hepatitis B, it's even, it's actually more complex, because the diagnostics are not as straightforward. So even once someone's surface antigen positive, you still got to figure out what phase of disease they're in, with additional serology for e antigen, HBV DNA, et cetera. And one of the things we have not really been very good in North America is about implementation of hepatitis B screening with point of care tests. This is done a little bit more in low and middle income countries with high prevalence of hepatitis B, but at least to my knowledge has really not been implemented in North America very much. And I think we probably should be thinking about that, is using more, thinking about how to integrate hepatitis B point of care testing, but it will be important that we have those follow-up tests for the additional serology, which at least for now, until we move to a surface antigen positive treatments approach, are required to figure out who and who needs treatment and when.
Yes, and I think that the hope is the hepatitis B does become a little more simple. It is challenging, even when you're talking to the fellows that are going to go out into the community to be general gastroenterologists. Their eyes kind of glaze over when you get to hepatitis B, and we do this all the time, so I think of it as pretty simple. But when you see that reaction in someone who has every interest in understanding how this works, we know that we have to make this algorithm, despite the fact that diagnostics and therapeutics are going to become potentially more complicated, we have to make this simple.
Couldn't agree more.
I really want to thank you, Jordan, for engaging this conversation. I think that COVID has disrupted all kinds of things. It has given us increasing amounts of alcohol use disorder. Drug addiction has taken away all of our harm reduction services, or at least disrupted these in many places. In the US, it has become politicized, so that now we have additional political conversations in medicine that we never imagined that we would have. But when we're looking at the incredible data presented at AASLD, considering simplistic models, how to take COVID and take an advantage of it, looking at this as a screening opportunity for viral hepatitis B and C, like Jordan, you were able to. I mean, I really want to encourage everyone out there to continue to fight for elimination. This is really important. And when we look at 5 years from now, when we are going to, the work we do now will have decreased the risk of uncurable liver cancer or complications that could have been avoided, and transmission of virus, we're really going to appreciate the fact that we have not forgotten about other viruses during the COVID pandemic. Any closing thoughts, Dr. Feld?
Thanks, Nancy. I think you really hit on the highlights. I think we want to make sure that there's no question COVID has interrupted many aspects of the cascade but I think it has potentially presented some opportunities. We need to leverage the public health approach to an infectious disease, use some of the diagnostic developments, maybe even some of the strategies for vaccination that have worked so well for COVID to try to translate those to hepatitis C. And then ultimately, I'm still confident. I'm always the perpetual optimist that we may have been a little sidetracked, but we'll get back on track and get ourselves on track for elimination. Maybe not quite by 2030, but hopefully not too long after.
Thank you, Jordan.
Thank you so very much to Drs. Reau and Feld for sharing that engaging discussion, and thanks to our listeners for joining in. As a reminder, to view the full educational program online, Lessons from Lockdown, click on the link in the show notes. And please be sure to check back regularly for more episodes on important infectious disease topics.